protección del paciente, y para este año la idea fuerza es la seguridad del diagnóstico, muy vinculado con lo que vamos a tratar durante esta actividad de cierre. Hemos tenido una tarde en la que se ha entregado una información relevante y además con debates interesantes en los múltiples workshops realizados. No obstante, aún queda un interesante diálogo en el que expertos nos entregarán algunas ideas acerca de qué podemos aprender sobre sus experiencias que han sido exitosas en materia de seguridad diagnóstica. Quiero dejar con ustedes a quien va a moderar este panel, Sir Liam Donaldson, quien va a estar a cargo de entregarnos su perspectiva, su análisis, y además conversará con los distintos expertos invitados acá a esta ocasión. Sir Liam Donaldson es enviado especial del director general de la OMS en materia de seguridad del paciente. Bienvenidos.
Good afternoon, everybody. This is a very timely subject to be discussing. Diagnostic safety over the years has been a series of incidents that everybody's seen, common, analysed, talked about, but it's never been a specific priority in the patient safety world, even though we believe it's one of the most common sources of avoidable harm. The good news is that, and it's I think an open secret, there hasn't been a formal announcement yet, but the WHO's work to hold World Patient Safety Day 2024 is going to be on the theme of diagnostic safety. So that will raise the profile of this subject that has been badly languishing, I think, in the less prioritized areas of patient safety. We've got 35 minutes or so for this panel discussion. And I'm only going to say a few things by way of introduction, but then turn over with some questions to my two colleagues. Wrong diagnosis, delayed diagnosis isn't the whole story on diagnostic safety, but it's the one that raises a lot of concerns. For the patient and family, it can cause distress, depending on the severity, confusion, anger, bitterness, resentment, and almost the worst thing of all for somebody who suffers or their family suffers a great tragedy as a result of unsafe care. Going forward, it defines them. They are known as the person whose child died in such and such a circumstance. And in their mind, the world of what if is ever present. What if it hadn't happened? Why did it happen? And then on the disease outcome or outcome front, death, disability, and reduced survival are three very prominent features of diagnostic safety. There's a lot of change happening in this field. Health services around the world have always been under pressure, but the modern healthcare is complex, fast-moving, pressurized environments with multiple interacting components. And in the mix of that is getting the patient the right and the most timely diagnosis. The aging population complicates our view of this. Multiple diagnoses in many individual people is a relatively new phenomenon. And then finally, the whole question of diagnostic information and technology is diversifying and fragmenting, and it's not yet clear how all of the personal diagnostic information that's going to be available directly to patients and members of the public through easier to use technology and monitoring. It's not clear how that is going to redesign healthcare systems and in what way, but it certainly will. And then finally, a back of the envelope calculation I did earlier this afternoon, thinking about a health system or a large hospital with 10,000 senior doctors. Imagine each of them made 10 diagnostic decisions a day, and that's not very many for a busy clinician. That's 100,000 decisions about diagnosis
decisiones en un solo hospital en el mundo, y cada decisión tiene beneficios potenciales y también potenciales riesgos. Así que es un problema de tiempo, son problemas serios.
In policy making in patient safety. Over to Sue first. Sue, your introduction didn't do full justice to the work you've actually done in this field. You spent time in an agency which was, or a charity, an NGO that was responsible for doing good work on diagnostic safety. But how did your journey on patient safety more generally lead you here today and sit on a panel to talk about this subject?
Can you hear me? Yeah. Thank you, Liam, and also thank you to the organizers for the invitation to participate. I'm very honored to be here. What brought me here to talk about diagnostic safety are both my son and my husband. 28 years ago, my son Cal was born a normal, healthy newborn. But because of a series of diagnostic errors, Cal suffered brain damage when he was 5 days old in the hospital from his newborn jaundice. Today, Cal is 29. He is has multiple disabilities, and but he's funny, he's smart, and he's a wonderful young man. But he lives with disabilities and challenges that he should never have had because of these diagnostic errors. 4 years after Cal, my late husband had a pain in his neck, and we went to our local doctor. They diagnosed through an MRI that he had a mass in his neck, and the mass was taken out of his neck. We were told it was benign, but little did we know that the pathology actually was malignant, and that pathology got lost in the healthcare system. My husband went 6 months without treatment, and during that time, the tumor penetrated his spinal cord. And 3 years later, he died from that. You know, he slowly became, he went through chemo, we went through surgery. He slowly became disabled just like my son. But because of those diagnostic errors, I was widowed, and I had a little boy with a disability, and during that time, we had a little girl. So that's what brings me here. But what also brings me here is the hope, because what I saw after that is mothers who also had children with brain damage from jaundice. We got together, we formed an NGO, and we called our system, our healthcare system, who failed our families, to help us create a safer system for newborns. Over some time, we worked together, and together we did change the standard of care, being powered by mothers in the United States and Canada. That's what brings me here.
Thank you, Sue. Hardeep, your journey's been a little different, but it's been a deep journey. And tell us a little bit about how you got here today and why you're here to tell us about diagnostic safety.
Sure. Thanks, Liam. And thank you for inviting us. Before I start, how many of you, either yourselves or a close family member of you, has had a misdiagnosis in the last 5 years or 10 years? I see about a third of the room has raised their hands. So this is the reason why I'm here. I was fascinated by how doctors think when I went to medical school. And I wanted to sort of do something, study about it, but not until I got into practice in rural East Texas, full-time as a GP, doing primary care, and I started seeing all these patients who were coming to me with misdiagnosis that I realized, oh my God, this is a real problem in healthcare. So I started my research career in early 2000s, soon after the IOM report came out, To Err is Human, and I realized they had not covered the topic of diagnostic error at all, or very minimally. So I started, through research grants, I started assembling a team of people who helped me put together some sort of force, bandwidth to do research in the area. We quantified the types and origins of diagnostic errors. So number one, in the United States, we quantified that about 1 in 20 US adults will have a misdiagnosis every year in the outpatient setting alone. And that seems to be a very high number, but that is corroborated by not only data from other systems such as hospitals, but also patients. About 12% of patients have told us that they've had diagnostic errors, just like you all did, either themselves or a close family member. So this has been quite an interesting journey. We've been able to sort of quantify the extent of the problem. And we found three things that have sort of resonated with what the research is showing. One is, it's the common problems that get missed. It's not the rare diseases, it's the common conditions, the common diseases, the pneumonias, the cancers, the heart attacks, the strokes. Second is the basic clinical skills, such as a history, physical exam, listening to patients. That's where we are not doing a great job. And my research is sort of focused on that, which is sort of really the area that I'm very interested in. And lastly, it's the stuff that gets missed in the electronic medical records or just data systems of any kind. So sometimes there's information that gets buried. So we've been sort of thinking about these things over the last about 2 decades or so.
Okay, and just taking a step across to the changing world that I referred to, Sue, how do you think patients will welcome having more diagnostic information available to them from smart devices, from perhaps going to a primary care center where a big scanner that 10 years ago would have been in a hospital is just handheld by the primary care physician and the diagnosis made very quickly. Do you think that's a good thing, or do you still like the process the way it is?
Well, you talked about the words what if, with both Cal and Pat. One of my what ifs is, what if I had had access to the clinical labs, the pathology? What if I had had access to a diagnosis that failed to get communicated to us? So in the United States, we have passed a ruling as of 2021 called the Faster Cares Act, where information now is, everything in our electronic healthcare record is available to us. And I think it is a safety issue. So I think it's going to empower us with far more information that can get buried or lost. And so we need to be more informed as patients and have that information at our fingertips, so we can speak up when we see that, my son's bilirubin had never been taken. And when it was taken, it was never informed. We were never informed of it. In Pat's case, I could have had access to the pathology and the reports. So I understand that there's anxiety about this for some, but I think from the patient world, we're hearing loud and clear. And research has shown that patients want to have access to their diagnosis and their lab results as soon as it's available.
And Hardeep, have you probably seeing this already in your practice? I mean, do you have patients that come in and say, these are my liver function tests, and I think this is what it means, and this is a scan that I've had, and I'm interpreting this way. Do you agree with me? In other words, shifting the balance of power in the relationship.
Yeah, well, it's time we shifted the power. Absolutely. Patients need to have this information. They need to have it urgently, immediately. The only caveat, I'm a researcher, so I have to ask tough questions. So we have found a few times when there are potential unintended consequences of patients getting this information before the physician can explain it to them. So I think patients are going to need support to understand this information. Not everybody can get all this information expeditiously, because some patients don't use, for instance, the patient portals. They're going to need support. And we're going to have to figure out how we can communicate this information to patients in a way that they can understand and act upon the information immediately, including counseling them, saying, you might be seeing information in your medical records that is sensitive. Would you like to see this information? So there's increasing sort of forces that are sort of guiding us towards the right strategy. Some of these strategies are still evolving, but I think some patients would probably say, I want the doc to call me first. I don't want to see it myself. Versus some like Sue would be, tell me everything right now. So there's a little bit of a difference in opinion on some patients, but I think most patients want this information right away.
Yeah. I mean, one of the most tragic situations, and I think let's talk about it systemically, is the things that are not the result of clinical decision making or poor clinical decision making or shortfalls in investigation, but they're things to do with the way that information flows within health facilities. And I think the most tragic of all is and I've heard this directly from friends, and you asked about personal experience, but whereby basically several people that I know have suffered an advance in their cancer diagnosis purely because they've taken a no news is good news philosophy. Yeah. So they are told, we'll be doing this test, you'll hear from us. They don't hear from them, and they assume, okay, this good news. But really, the test results have got lost somewhere in the system. Seems to me that we should be able to deal with those information processing things much more quickly and comprehensively than we've done so far. What do you think about it, Hardeep?
Absolutely. So, ultimately, we've got now information technology that knows which patients have had what results, which ones are abnormals, and which ones have come back into our system so that we know that they've been followed up or not. So we've been developing algorithms which can help identify patients who've had abnormal test results, let's say a chest X-ray that shows a potential cancer, but they have not come back for their CAT scan in, let's say, 30 days. And the system can pick it up and say, this patient who's had an abnormal test has not come back in 30 days. We need to call them proactively. I heard a lot of sort of proactiveness in patient safety, right? So we need to reach out to them proactively to make sure they don't get lost or follow up. So we have the technology, the people, and the processes right now to solve the problem, but we're not doing it yet.
Yeah. Sue, any thoughts on that?
Well, the fact that we're not doing that yet just takes me back to we have to be more empowered as patients to have access to everything basically real time. And thinking about Hardeep's comment about, patients need help interpreting, what they get maybe even before the doctor. And I think there's a use maybe with AI to take some of that information and make it into understandable language. So when we do get that information, we can understand it. So that's, I think in the meantime, as we develop the technology to grab that information and follow patients, we have to be really proactive in empowering the patients with that information.
And just to completing a little loop that's in my mind, Sue, thinking about your experience with Cal, I can remember you telling me that bilirubin, after it happened, bilirubin was not a subject in any of the mother and baby books at that time. You remember?
I do remember that.
Yeah,
yes.
and you talked to one of the authors, and she was quite indignant that you were raising it.
Yes.
And yet a common problem, but it wasn't there.
Yeah.
Do you think?
One of the breakdowns in getting a diagnosis is a diagnostic process. One of the breakdowns in the diagnostic process with Cal is that the healthcare professionals failed to tell me that jaundice could, in rare cases, cause brain damage in your newborn. So my provider didn't tell me, the nurses didn't tell me, and all the prenatal books that I read before I had my son, I went to breastfeeding classes. Nobody told me that jaundice could cause brain damage in your newborn. And so when I learned that, I felt deceived by our healthcare system for not informing the mothers, for not empowering us with this information. So the mothers group that I mentioned who's changed the standard of care, we went to the editors of the newborn prenatal or the prenatal books, and we said, please, can you include this? And at first they said no, because there's no evidence, or we don't want to scare the mothers. And we've changed that. We've changed that. This scaring the moms, we need to be wary. We need to be on our toes about things that could harm our babies.
So do you think that the diagnostic process, where patients probably don't even think of it as a process, they think of it as an event,
right,
needs to be more debated? I think one of the byproducts of COVID, I think there are many, but firstly, the public understand epidemiology better than they did before. They've looked at all the graphs, but there's been a real in-depth media coverage and public discussion about COVID, how it's diagnosed, long COVID, these sorts of things. Seems to me that there are many other diseases that people have that really there's level of information for them is relatively superficial. Would you think so, Hardeep?
Yeah, you know, you mentioned diagnosis as a process, and it's important to realize that it's an evolving process. Sometimes it takes time to make the correct diagnosis. Things change. Patients sometimes present with undifferentiated symptoms. Things get clearer over time. There's a lot of uncertainty in the diagnostic process. Over the last few decades, we've sort of gone into this thinking that this is not a one-time thing, but it's a process that can be defined into certain dimensions. So we've had the doctor-patient interaction dimension, there's a testing dimension, there's a consultation dimension, there's a patient dimension, and then of course, there's a follow-up dimension. So, you know, Sue's case, for instance, is a follow-up problem. And that makes it easier to communicate and improve upon. So we can say, diagnosis is a process, it occurs within a system. So it's not all about what happens in a physician or a clinician's brain, but it's a process that unfolds over time across different systems of care, across different care settings. And that makes it a little more sort of understandable, not just to the public and the patient community, but to our community as well, when we are trying to understand and improve it.
Yeah, go ahead, Sue. Yeah.
I have a comment about just that diagnostic process. It was really helpful for me to understand the diagnostic process, and something that we did when I was working with the Society of Improved Diagnosis of Medicine is we brought together 21 patients, all who would experience a diagnostic error. Most of them lost family members because of diagnostic error. So what we did with our patients is we took this process and we had them tell their stories and say at each point in the process, they identified all the breakdowns. And so that was really powerful for a patient to see all of the process, the pieces of the process, how complex it is. And that made them appreciate, how complex it is. And then we found solutions for some of those issues.
This may not be generalizable to all parts of the world. I mean, it very much depends on the health system, the point I'm going to make. But one of the big problems in the people I talk to in the UK and in some other countries is lack of continuity of care. So they're coming back, often seeing a different person, different doctor each time. And the doctor reading the record, even an electronic medical record, doesn't compensate for the subtlety of the patient's situation. And if you couple that with the tendency of people to be let go, we can't find anything, so nothing means you haven't got anything wrong with you. And yet then these situations come back to haunt people, that they didn't stay with the patient long enough, or the patient didn't stay with the same care provider to let them keep wondering, getting to know them as a person, understanding why they're continuing to describe pain when you think, well, there's no reason for it. So continuity of care. I mean, Sue, that must be, from a patient point of view, very important.
It's very important. And if you look at both my husband and my son's case, I mean, my husband, we started in the state of Idaho in the United States, where he was diagnosed with this tumor. The surgery took place in another state, in Arizona, where there was a team of doctors. It was a very complicated surgery. There were students involved as well. And then we were discharged back to Idaho. And then when we learned that there was an error, his care actually took place between Idaho and Houston, another state. So you see, I was the quarterback. I had to be the quarterback to make sure, to collect all the documents, to communicate between doctors. It was a full-time job. And with Cal, it's the same. Cal has maybe 15 doctors, caring for different parts of his disabilities. And again, the continuity of the care is very challenging, and that impacted his diagnostic error tremendously.
Yeah.
Between nurses, residents, neonatologists, pediatrician.
Hardeep?
Yeah. Well, how often do physicians hear from other physicians saying, hey, remember that patient that you saw a few months ago? And we're like, wait, what happened to that patient, right? there is so much discontinuity now in our care. What we've been sort of trying to do more is to build better feedback loops back to the clinician about what happened to their patients, so they get some idea about what was their performance like. One thing we learned from cognitive psychology is, one, we did a study where we showed that doctors are in general more overconfident, and they often don't realize they need help. But one of the ways you combat overconfidence among clinicians or any other professional is you give them feedback. You give them feedback on their own performance so they can learn about what happened when they were taking care of the patients. So we've been trying to figure out how best to deliver this feedback, whether it's through information technology, electronic health records, and other systems, and standardize that feedback so people can keep learning, so clinicians can keep learning about what's happening to their patients over time.
Yeah. I mean, I must have read in the last couple of months 3 or 4 media stories of young adults who were reassured that this wouldn't be anything serious, and then they came back, I think in 2 cases with pancreatic cancer and another serious cancer. So this decision of letting go of a patient or saying to them there's no need for any further investigation is a very, very difficult one. I mean, I don't know how you set a protocol, I mean, the protocol for individual diseases, but how you take a general approach that would guard against those sorts of risks.
Well, one of the things we sort of in the teaching is what we sort of try to tell clinicians to think about is what else could it be, and challenge yourself. It's this form of critical thinking that you can teach. We don't teach a lot of critical thinking in medical school, at least. But one of the things we've been trying to say, we had a paper in BMJ that talked about all the educational strategies that could be used by clinicians to achieve diagnostic excellence. And one of them was critical thinking. That means you have to stop yourself and ask, am I missing something? Because the patient is back the second time and the story has evolved. Could I be wrong? And so that critical thinking, you have to sort of inculcate in your practice. You just have to integrate that.
Okay, if it's the same doctor, but if it's a different doctor, then
absolutely.
Yeah. I mean, it's almost sometimes when you read the investigation, it's like the pilots and the plane they're tapping the altimeter to see whether it's broken, and yet the plane's height's falling. It's locking in too early to a definitive presumed diagnosis. I think that's the difficulty.
Yeah. Well, one thing we're not doing very well at least in medical school, we're not teaching humility. But I think if we teach humility and curiosity, in addition to all the basic science knowledge that we are giving to physicians, I think we'd be better off, making better diagnosticians.
So, Sue, if you were to start thinking about policy priorities for policymakers, health ministers, health leaders on diagnostic safety, as viewed from your experience and perspective, what would be the list of things that would occur to you?
Well, I don't know if I have a list of policies, but I have, if I were to speak with the ministries of health, I would first say, engage your patients, your citizens, your caregivers, to create policy that matters to them. And so in the United States, I'm part of Patients for Patient Safety US. We're a chapter of WHO's Patients for Patient Safety Global Network, and we're working on some policies. Well, I should say we're working on some legislation. One is Improving Diagnosis in Medicine Act, that we think we need our government, our agency and our government who focuses on diagnostic safety needs more money. So we are actively advocating for this act. We're also actively advocating for a National Patient Safety Board in the United States at the White House level, because we have no one in charge of patient safety in the United States. So we're advocating for a new bill on that. Now, another thing that we're really advocating for, and it's not asking the policymakers to do this, we're asking the policymakers to join us. And what we recognize, we've been talking a lot about measurement and evaluating our healthcare systems. And, we patients have identified that a lot of the evaluations and the questions that we are asked to evaluate our healthcare system weren't really created by the patient community. So we've launched a new initiative with our policymakers. So CMS, HRQ, NQF, they're all joining us. And so we're going to bring together all these patients to identify questions about safety and diagnostic safety, so that when we evaluate our healthcare system, answer those questionnaires, we're answering questions about diagnostic safety, because right now we're not getting asked that. So it's not we're asking the policymakers to do it, we're asking them to join us. So it's kind of like what Mike Durkin said later on before this, is that this is a patient-powered initiative that we don't have to wait to be invited by the authorities.
Yeah. Hardeep, just before you answer that question, it strikes me that sepsis is a very good example because it's a circumscribed, important area, but the way of ensuring safe diagnosis has been very carefully mapped out, and you could give a clear policy. Should we be doing that in other areas? Should we be taking other diagnostic groups and mapping out that similar approach to ensuring that there are no mistakes or few mistakes? And
yeah, I have some thoughts about that. And one of the things is we do need some disease-specific approaches, but right now we have more of a systems and a process problem that we need to tackle. And I'll give you the example, what Joe Chiani, Rory Staunton's story. So some of you who were here this morning, Joe Chiani was talking about the child who got misdiagnosed with sepsis, was sent home and died because the WBC or the lab count was missed. Well, actually, not only his white cell count was missed, but he had mottling of the skin. That means his skin was black in the emergency room, and he was still sent home because nobody did the physical exam. Right? So here is the issue, when I mentioned earlier, basic clinical skills, listening to the patient, doing a physical exam, and then figuring out the tests based on the physical exam. That still holds true. So if we can do a disease-specific approach, I would say first we have to do a disease-agnostic approach where we tackle all the systems and process issues and some of these issues that we're talking about at not a disease level, but at a system level, at a process level, because we find multiple types of conditions keep showing up in any setting. So in primary care, we did a study. In 190 diagnostic errors, there were 67 different types of diagnoses. And that kinds of studies are now prevalent all over. So no matter what condition you look at the emergency room, you'll find like there'll be a list of 60 or 80 conditions that are missed in the emergency department. So we can't have 60 or 80 disease-specific, solutions in the emergency room, right? So that's why we have to take a disease-agnostic approach. So my view is more of a broader structural systems and process view.
okay. So your thoughts on priorities based on your work?
Yeah, we could keep focusing on clinicians, but that's not going to help right now. I think what we need to do is not only focus on clinicians, but fix the system around, which is sort of my point earlier. There are now plenty of tools, strategies, and innovations that healthcare organizations, ministries, and health systems can use that can advance diagnostic excellence or diagnostic safety. There are now ways we could measure diagnostic safety at an organizational level. So creating a learning health system for diagnostic safety. So what's a learning health system? Learning health system is essentially any system that can learn from its data and improve on that data. So you learn, you improve, you put solutions into practice, and then you measure again, you learn, you improve, and you put solutions into practice. To create a learning health system for diagnostic excellence, we have the tools now. We do a risk assessment. We created this tool set called Safer DX Checklist. It's a proactive risk assessment tool. It's on IHI's website. It's also on the Joint Commission website. You do a risk assessment on your organization. How well are we doing in this organization in terms of diagnostic safety? Depending on those results, you can also then put into place some measurement strategies. So we say we have to learn from 4 sources of data. You have to learn from your data that you're already collecting, whether it's lawsuits, root cause analysis. You have to learn from patients. You have to learn from clinicians. That means clinicians have to be engaged reporting diagnostic errors. They know about diagnostic errors. They don't report them. And lastly, you have to learn from electronic health record data systems. So we have these tools now that are freely available. AHRQ has one of them called Measure DX as well, which is freely available, that I would encourage institutions to use. And policymakers can make this a structural measure. I don't think we're ready for outcome measures. All organizations can actually look at their outcomes, but I would say every policymaker should think about what structural measure can I use for diagnostic safety in all my health systems.
You both sort of answered my last question, but the final take-home messages for ministers and policymakers, Sue, what would you want them to take to heart on diagnostic safety?
Well, my message would be that harm from diagnostic error is profound. You know, my family and I went to a very dark spot in our life. And what really brought me out of that darkness were the leaders in healthcare who invited me into their world to help create solutions. So my message to you is, to the ministries of health and all of you, is embrace the wisdom of your patient community. Create structures in your organizations, in the government, at your healthcare systems to bring in your community, to bring in your patients, to bring in your moms, listen to them, learn from them. Have measures, like Hardeep was saying, have measures to learn from your patients, implement those, and then take action with your community. And never, I have to say, when my husband was dying, he said to me, Sue, never give up on patient safety. So I ask all of you, never give up on patient safety and getting a right and timely diagnosis.
Hardeep?
It's hard to follow Sue, but I'm going to be, as a researcher, I'm going to say, if you are a minister or a health system leader, you Google SaferDX checklist for diagnostic excellence. You find the 10 items, you give it to your patient safety people and ask them, what's your score? Every single hospital needs to have a score on that SaferDX checklist, and you'll get the answer what you need to do next.
Try and put all your energy into raising the profile of this subject in World Patient Safety Day 2024, the 17th of September. We'll be doing what we can from WHO to ensure that it gets really big exposure across the world. But thank you today for a very interesting and insightful discussion. Sue, Hardeep, your time here today has been invaluable. Thank you.
Thank you, sir.
And thank you, everybody, for coming.
Should we get
Muchísimas gracias a nuestros panelistas, sin duda muy interesante tal como cerraban este panel. Esperamos profundizar el día de mañana también esta temática tan relevante. Hemos llegado así al final de este primer día de la sexta cumbre global ministerial sobre seguridad del paciente en Chile. Mañana, 18 de abril, iniciaremos el segundo día a las 7:45 horas. Es la hora del registro. Por favor, le solicitamos traer las credenciales que se le entregó hoy día para poder hacer ingreso también al GAM. Tendremos una sesión plenaria acerca de la complejidad de mejorar la seguridad de la asistencia sanitaria en un mundo cambiante, una mesa redonda con autoridades para conocer los logros y desafíos de las cumbres ministeriales. También conoceremos la situación de la seguridad de la atención aquí en nuestro país y el aspecto económico en la seguridad de la atención, así como la voz de los pacientes. Finalizaremos con las principales conclusiones y compromisos de esta cumbre. Los dos mensajes antes ya de finalizar. Por favor, los traductores, entregarlos afuera, y todas las autoridades y jefes de delegación que están invitados a la actividad en el museo, por favor, contactar a su medio de transporte. Va a haber una guía para aquello. Que tengan una excelente tarde. Muchísimas gracias por haber venido.
Where do I go? Never tried, never know. How long do I have to climb up on the side of this mountain? Look up, I look up at night, and it's a moment, the speed of light. I'm up, burning trees, every chance of breath, it's a gentle scene. How low I can stay, with my head topped from the sand. I'll start before I can stop, before I see things the right way out.